Hi, my name is Dr. Bijal Shah from the Moffitt Cancer Center. This is a poster looking at healthcare resource utilization and costs associated with obecabtagene autoleucel, newly approved CAR T-cell therapy for B-cell ALL. What we really wanted to focus on in this poster was, one, who is getting high-grade toxicity, and number two, how does that toxicity inform healthcare resource utilization and overall costs as a consequence. It's not going to come as a big surprise. When patients have toxicity, it's more likely to lead to a longer hospitalization and more costs associated with that. But we really want to try to better understand that a little bit, right? We have newer drugs, tocilizumab, of course, but also now emapalumab, anakinra, and so on. Again, this was done before. Those drugs were routinely used. So we're really going to talk about, when we talk about pharmaceutical costs, I think tocilizumab really is going to be the big driver, and you're going to see that in the data here. So first, big picture, if you have high-grade CRS, you can see that it's about $24,000 in additional costs about $20,000 in additional costs relative to having only grade 1 or grade 2 CRS. And the bulk of that is still hospitalization time. As you go into higher grade ICANS, now we're really seeing a differential, right? Now we're talking about a $45,000 increase in cost, and again, largely driven by these extended hospitalizations, okay? The other thing to keep in mind when we're talking about the hospitalization for CRS and ICANS is there's a component of ICU utilization too, right? Where you're going to also increase your costs related to that for monitoring, in some cases with severe ICANS, intubation, and so on. So this is where some of these pieces really come into play here. We break down now the costs that are, again, what we're seeing as a consequence of the CRS. In this case, 2 patients ended up using the ICU. Again, similar with ICANS, 2 patients using the ICU. When we talk about having both CRS and ICANS, you can see it was a total of 3 patients now. But here we are with our costs, our breakdown of what's driving our costs, hospitalization being the key feature, ICUs being a key feature. And so it says we got to find a way to decrease that. Again, one of the nice things about this 401BB based product and the split dose infusion and the low affinity binder is it does seem like we're seeing that low toxicity. If we continue to see that the efficacy is maintained, there's going to be a big question, right? Is it time now to switch to ObeCART as a preferred CAR T in B-cell ALL?